Okay, I'm going to go right ahead because I think I have a full set of slides here too. Okay, a full-term African-American infant examined at 30 hours of age appears jaundiced without any other remarkable physical findings. His birth weight was 3.6 kilos and he now weighs 3.4 kilos. Determining the results of which laboratory studies would be most appropriate. Total bilirubin and maternal and baby blood types. Bilirubin, maternal baby blood types, hematocrit and retic. And then it goes on. In addition to that, you can get a direct bili or everything with a G6PD. Okay, so, okay. We're divided. I was going for B, making this a kind of a question of, don't do too much, but do enough to make sure that that the baby's not in trouble. But D would be, if the baby did have hemolysis, that would be a very reasonable choice. But we don't know that yet. So what I was getting at here was the causes of early jaundice. So this baby, the first time you're examining him, is already a little over a day old, but he could have been jaundiced when he was only 12 to 24 hours old. So you need to make sure that he doesn't have a blood group incompatibility with his mother. So if you knew the mom's blood type and RH, you could probably just get away with doing a total bili. Other things to look out for, risks for hyperbilirubinemia, would be a sibling or a parent who had to have phototherapy, a late preterm baby who was less than 37 weeks, East Asian background, ethnicity, exclusive breastfeeding, a reason for excessive bruising or a cephalohematoma, and then, as we talked about, if there was hemolytic disease going on. Okay, part 2 of jaundice. Physiological jaundice is more severe in preterm neonates compared to full-term neonates because the preterm neonates have increased hemoglobin levels, B, increased heme degradation, C, increased hepatic uptake, D, decreased hepatic conjugation, and E, decreased enterohepatic circulation. Okay, decreased hepatic conjugation. Now let me look at these, make sure that's correct. But a lot of people said decreased enterohepatic circulation. And I can see why. But here's a little figure showing what happens when red blood cells are broken down. So the heme is broken into bilirubin, that's heme oxygenase, and that's a fast step. And then the bilirubin is bound to albumin in the circulation. When it gets to the hepatocyte, there's a carrier-mediated uptake into the hepatocyte, which can be a little bit slower in preterm babies, but shouldn't be the major factor. And then the conversion to a conjugated form is the step that can be slower in preterm babies. And then the enterohepatic circulation, let me see if I can get the laser to work here, would be babies do have, because they're maybe slower to feed, maybe they've lost some weight, not eating well, they could have a slower transit time through the bowel, especially if they're preterm, and that would give more time for the bilirubin to be converted back into a form that was like an unconjugated form. But that would mean that they had a decreased enterohepatic circulation, and they actually have increased enterohepatic circulation, not decreased enterohepatic circulation. But I can see why that would be confusing because it just confused me. So, this is just another way of showing it. A full-term infant is born following a prolonged second stage of labor. Her initial tone is poor and she is not crying. She is quickly dried, her mouth cleared of secretions, her head positioned to open the airway, and the soles of her feet are flicked. No spontaneous respirations are noted after these initial actions, and her heart rate is below 80 beats per minute. The next best action would be to apply a face mask to begin PPV, give continuous positive airway pressure, provide 40% oxygen, provide further stimulation by rubbing, or repeat clearing the oropharynx. Okay, good. So I think that if I was doing a board question, I would probably put an NRP question on there. And so it looks like almost everybody got that. So if a baby doesn't begin breathing immediately, you don't know whether it's primary apnea or secondary apnea, but if the stimulation doesn't work, then it's probably secondary apnea, and further stimulation isn't going to help. So it requires PPV. And this is just the top part of the newborn resuscitation algorithm. What I wanted to point out here is when you get to the bottom, there's a choice. If the baby is gasping, that means that they're having ineffective respiratory effort. Or if they're apneic, then you do PPV. If there is some breathing, but it's labored, retractions, or if there's persistent cyanosis after you've waited a few minutes for transitioning, then you could consider CPAP or increasing some supplementary oxygen by a mask. Nearly all neonatal seizures occur as a consequence of an identifiable etiology. Which would be the most common reason for a newborn to experience a seizure on the first day of life? Hypoglycemia, hepatic ischemic encephalopathy, an inborn error of metabolism, meningitis, or a congenital brain anomaly. So it's pretty evenly split between hypoglycemia and HIE. Let's reveal here. So the most frequent causes that we see now, even though we kind of obsess about hypoglycemia because it's easily avoidable and it'd be such a shame, but the most frequent cause by far in 2/3 of cases is hypoxic ischemic encephalopathy. And then that's followed by the number 2 reason would be some kind of intracranial hemorrhage. Third reason, a stroke, and then it goes on. I'm not sure if these next ones are actually they're more unusual, so there are a few percentage points, so I'm not sure they actually go in this order, but other reasons that you could look for would be an infection, torch infection, meningitis, encephalitis, or a metabolic reason, as we mentioned, the hypoglycemia was on there, the question for that reason, or congenital anomalies of the brain. Drug withdrawal also I put down, it is maybe like reason number 10, but it can happen. So just as a reminder that HIE is a multi-systemic, multi-organ failure, so you're going to see other effects. There might be a question on what else you would see. So with the brain, you could see seizures, loss of vascular autoregulation, SIADH, the kidney, some kind of anuria or acute kidney injury. You can see adrenal insufficiency, hypoglycemia, coagulopathy, and hepatic necrosis. For the gut, you can see an intestinal perforation or neck. Lungs, you can see meconium aspiration or pulmonary hypertension. And then you can have a poorly functioning heart, so cardiomyopathy or impaired contractility. Question 5. A full-term newborn is delivered emergently for fetal bradycardia. He emerges limp and covered with meconium. He is intubated and then placed on mechanical ventilation. After 2 hours, his chest X-ray shows adequate lung expansion, but his PaO2 is 30, despite being on 100% oxygen. Which clinical sign or signs would support the diagnosis of PPHN? A is absence of tachypnea or retractions. B is a brisk cap refill time. C, labile pulse ox readings. D, pre and postductal different less than 5%, or E, a split second heart sound. Okay, the answer I'm looking for here is C, so labile pulse oximeter readings. The second heart sound is fixed usually, or could be, it doesn't have to be. And then D, the pulse ox difference should be greater than, I think it's 10%. So even under normal circumstances, babies are born with a relatively high pulmonary vascular resistance or pressures. And there's two major things that influence the fall of the vascular resistance, and that would be activation of stretch receptors following the first breaths, and then also oxygen acting as a pulmonary vasodilator. In PPHN, the baby stays hypoxic, and that prevents the pulmonary vascular resistance from falling. Now, I know that I wasn't sure if this would show up, but it's to remind me to kind of walk through why in PPHN, not only do you have hypoxia, but you also have systemic signs of shock. So if your pulmonary vascular resistance is high, then the right side of your heart has to work harder, and you can have systolic and diastolic dysfunction. Some of the blood, if it's high pressures in the lungs, is going to get shunted through a PDA and go out to the circulation deoxygenated. And so overall, because the right side of the heart isn't working well, and some blood is being shunted away from the lungs, you're going to have less pulmonary blood flow. Less pulmonary blood flow means you get less preload into the left side of the heart, and then you have less, ultimately you have less blood circulating onto the systemic side. So you can see hypoxemia, acidosis, VQ mismatch, and then shock. So I think on the boards, a lot of times they present a case that sounds really bad, and you can't tell if it's a cardiac lesion or if it's PPHN. So I thought I'd go through a little bit some of the clues to differentiate between the two. So clues that it is probably a high pulmonary vascular resistance would be severe oxygen failure despite optimizing lung recruitment, very labile oxygenation that seems to be dependent on sedation or loud noises or something like that, and then a pre to post ductal difference of over 10%. And the differential diagnosis would be severe sepsis and congenital heart disease. Some of the congenital heart diseases that might come up would be something that was duct dependent, and so there was decreased pulmonary blood flow, like pulmonary atresia, or it could be something that's going to affect the systemic circulation, like a hypoplastic left heart or a critical coarct. So features in a scenario that would more suggest that it was a cardiac condition would be a relative absence of respiratory distress. If you have PPHN, you're still going to have respiratory distress. Some kind of strange sounding murmur or weak lower limb pulsations, an abnormal heart shape on chest x-ray, a relatively fixed oxygen saturation or a failed hyperoxia test, and the absence of systemic hypotension in spite of severe prolonged low saturations. Okay, moving on to a different topic. The radiographic features shown are pathognomonic for which of the following conditions? Cystic fibrosis, Hirschsprung's disease, meconium plug syndrome, necrotizing enterocolitis, or volvulus. And over three quarters chose D, neck, and that is correct, although it is always tricky to bring x-rays here. I think next time I do this, I'll make that the whole thing. But what it's showing is widespread bubbly pattern. It's a little hard to tell here, but it's got some dilated loops, and there actually is some portal venous air up in here. So pneumatosis is a feature of advanced neck. It's caused by bacterial translocation and then the production of gas in the submucosal layers of the gut. And the gas that the bacteria is producing can either appear as like a linear, looks like parallel train track appearance, or it's just a bubbly appearance. Usually you also see thickened bowel wall, so thick stacked loops, or bowel dilation. two different specialists can look at the same x-ray and disagree on it. So some of the things we look for to show it's a really severe case would be if there was free air, if there was gas in the portal venous system, or if there was like a fixed bowel loop that was kind of looked abnormal in the same position on serial films that were done like 8 to 12 hours later. Other things that might come up that would also cause very abnormal looking x-rays for newborns would be Meconium Ileus, and that's usually associated with cystic fibrosis, where the meconium is an abnormal putty-like consistency that causes a blockage. Usually it happens at the ileocecal junction, and so you see multiple very, very dilated loops. If they actually perforate before the baby's born, you can see peritoneal calcifications. Hirschsprungs can look very similar to any other kind of lower bowel obstruction, where everything will be massively dilated before the segment that doesn't have nerve cell endings in it. So you'll see large loops of bowel and scattered air shadows. But sometimes if they did do a barium enema or have that, you would see a transition zone that goes from the wide caliber bowel going down to narrow caliber. Meconium plug syndrome is a variant that's usually associated with maternal diabetes, and that can possibly, it's also kind of thickened meconium, but it can be potentially cured by doing repeat barium enemas. So you'll see filling defects on the barium enema. And then Volvulus is a little bit different appearance than the other ones, but it can have a very variable appearance. But it's usually a mid-gut issue where there's a malrotation, and then there's kind of corkscrewing or twisting of the bowel around a Ladd's band. And so usually you don't see as many bowel loops, but what you do see will look massively dilated, where you just see a few. But you can also see edematous bowel and stacked loops. So to finish up on NEC, which two laboratory features indicate that a neonate being medically managed for necrotizing enterocolitis requires surgical intervention? A, anemia and neutropenia. B, hyperkalemia and increased creatinine. C, hyponatremia and hypocalcemia. D, persistent metabolic acidosis and thrombocytopenia. Or E, rising CRP and leukocytosis. Wow, that's interesting, because I think last year that was hardly anybody took that choice, but that is the correct choice, so very good. So what we're getting at here is medically managed as opposed to surgically managed. So what's kind of part of the threshold in the decision-making process for going to surgery? So the clinical features of NEC can kind of be divided into abdominal signs and systemic signs. The systemic signs can be kind of vague, and that's why we do so many septic workups sometimes in the neonatal unit. Lethargy, temperature instability, hyperglycemia. Sometimes an early sign of NEC can actually be hyponatremia that's not explained any other way. Apnea, bradycardia, tachycardia, hypotension. The abdominal signs, emesis, bilious aspirates, absence of bowel sounds and increased abdominal girth, blood in the stool, that's kind of a late finding, tense, tender abdomen, or even a discolored abdominal wall. And here's a picture of a discoloration of the abdominal wall. So medical management means abdominal decompression, bowel rest, antibiotics for usually about 10 days, nothing by mouth, something for pain control, and then serial monitoring with x-rays, kind of looking to see if there's any peritoneal free air. Surgical management comes into play whenever there's dead bowel that isn't going to recover and scar down any other way than removing it. So that comes in if the baby is so sick that you think that they're not going to survive the medical management, or if that bowel goes on to perforate and they have free air. So laboratory markers of dead bowel would be high lactate and uncorrectable metabolic acidosis, and the consumption of platelets that doesn't resolve after the initial stabilization of the baby. Okay. A term infant of a diabetic mother, insulin-dependent diabetic mother, has a blood glucose level of 25 milligrams per deciliter after the first feed. The baby breastfeeds again, and the blood glucose level 1 hour later is 22. The infant is alert without neurologic signs of hypoglycemia. The next best action would be to A, feed the baby 30 ml of dextrose water, B, feed the newborn 30 ml of term formula, C, give an IV bolus of 10 ml per kilo of D10W over 10 minutes, D, repeat the blood glucose concentration in an hour, or E, start a continuous infusion of D10 at 80 ml per kilo per day. Okay, so the majority said to give the bolus, and then it looks like we're evenly split between feeding the baby again and doing a continuous infusion. And this, I think, is the hardest question that I have here. I was going for starting a continuous infusion of D10W, and so I purposely made C wrong because you should give, I think 10 ml per kilo is too much dextrose to give for our usual. But we'll go through it. So, important to recognize who would be at risk for hypoglycemia. That's probably actually more important than this question. So the at-risk infants would be late preterm, 35 to 36 weeks, small for gestational age, or the infants of diabetic mothers. And those, usually the hospitals have protocols where those babies are screened with a blood glucose a couple hours after birth. But we lack a universally accepted lower limit because we're not really sure what absolute number for the glucose concentration would predict permanent neurologic injury. It probably has more to do with the length of time that a baby has a very low glucose concentration. So for term infants, numbers thrown around can be anywhere from 30 to 45 milligrams per deciliter. Symptoms of low blood sugar are jitters and tremors, exaggerated Maro reflex, hypotonia, poor feeding, grunting. So the AAP does have some guidelines for how to manage hypoglycemia, and I'll show on the next slide their little schematic. But they say feeding is okay if the blood sugar is over 25 and there's no symptoms. This is the initial feed. But that by 4 hours of life, using that 25 mark is no longer acceptable, and you have to have a blood sugar over 35. You can do a glucose bolus or a constant infusion. But if you're going to do a bolus, it would be 2 ml per kilogram. And sometimes if you have a infant of a diabetic and they're low blood sugar because they're hyperinsulinemic, if you give a bolus, they can just make more insulin, secrete more, and you can actually get into a cycle where you're all of a sudden up to D20 on your infusion. So if you're going to give a bolus, you should start IV fluids after that. And IV boluses are definitely needed if it's an extremely low glucose level or if the baby has any symptoms that are attributable to the low blood sugar, like reduced alertness, hypothermia, seizure. So here is the American Academy of Pediatrics management, which is basically what we just went over, but I just wanted to point out that they have more than one acceptable way of dealing with the low blood sugar, but the important feature is surveillance and then having to have a higher blood sugar as time goes on. Okay, question 9. A mother entered an inpatient rehab facility when she was 5 months pregnant for addiction to prescription painkillers. She began a methadone substitution program and was taking 80 milligrams of methadone daily at the time of delivery. You're called in to discuss monitoring the newborn for neonatal narcotic withdrawal. The medical literature would support advising, A, breastfeeding is contraindicated if the baby's NAS symptoms require treatment, pharmacological treatment. B, narcotic withdrawal can present up to a week after birth. C, neonatal withdrawal is unlikely if the mother remained compliant with the methadone substitution program. D, once initiated, the average length of treatment with oral morphine is 3 to 5 days. Or E, withdrawal symptoms occur earlier with methadone compared to heroin. And we said B, narcotic withdrawal can present up to a week after birth, and that's the correct answer. So NAS is in the news now because we're having an epidemic. It's caused by it really means it can be caused by sudden discontinuation of fetal exposure to any substance, whether we have a treatment to give back to the baby or not. It can be secondary to morphine, heroin, methadone, prescription analgesics, antidepressants, and anxiolytics. But heroin exposure, usually you see earlier withdrawal symptoms and an overall shorter withdrawal. Methadone and Subutex, the exposure leads to a later onset and longer period of withdrawal symptoms. So we used to watch for symptoms for 3 days, and now we're extending that out to like 4 or 5 days before the baby goes home in the newborn period. There's no study that I'm aware of that's shown an absolute link between the amount of maternal misuse and the incidence or the severity of the neonatal withdrawal, but we do know that the majority of infants who are exposed to methadone and I can never say that, so I'm going to say Subutex, develop symptoms. The average duration in the literature of withdrawal once you start treatment and they have symptoms is 35 days. I think my experience has been it's a little bit shorter than that. I think our average length of hospital stay for baby once we start treatment is more like 24 to 27 days. Breastfeeding is contraindicated in NAS only if the mother is taking street drugs, is involved in polydrug abuse, or is infected with HIV. But that being said, a lot of times if the mother's on like 3 or 4 different medications, or if, let's say, that she's taking prescribed pain meds, but they're very, very high, we might have second thoughts about just how much was getting to the baby. Other problems to look out for, Hep C in 10% of mothers, illicit drug supplementation using on top over half of the mothers, and prematurity in 28% of babies. So another NAS question. Scoring systems are utilized to determine when opioid replacement is indicated to treat the NAS. The caregiver assesses the infant for physiological signs of narcotic withdrawal. Which one of the following would add to an infant's Finnegan narcotic withdrawal score? Firm stools, hypertension, hypothermia, myoclonic jerks, or sleeping more than 3 hours after feeding? And that's the correct answer is D, myoclonic jerks. I mean, if you were withdrawing, usually it's loose stools or diarrhea. Hypertension you could have when you're withdrawing, but it's just not something that's scored for, that the nurses score for with the Finnegan withdrawal scores. Hypothermia, it's usually fever that they're looking for, and they want the babies to sleep more than at least 3 hours after feeding. So what they're scoring for can kind of be broken down into CNS and autonomic symptoms and then gastrointestinal symptoms. So you score points for excessive high-pitched crying, for poor sleeping after feeding, for hypoactive Maro reflex, for tremors, hypertonic, myoclonic jerks, seizures, and excoriation. Tachypnea, fever, mottling, sweating, sneezing, yawning, excessive sucking, poor feeding, regurgitation, and loose stools. Did I say excoriation on there? Excoriation should be on there too. So the initial treatment option is to do things like keeping the lights dim, low noise levels, swaddling the baby, holding the baby constantly, and maternal participation in this has been shown to decrease the severity of withdrawal. Pharmacological treatment is only started if the baby continuously scores high. Morphine, so oral morphine is the most commonly preferred medication. Sometimes clonidine is used as an adjuvant, and phenobarbital is I see it very rarely now, used for non-opiate NAS symptoms. Okay, question 11. A male infant is identified as having bilateral multicystic dysplastic kidneys at 18 weeks of gestation. The amniotic fluid index was low since 22 weeks, and there was no leakage of fluid when he delivered at term. What non-renal features might the newborn have? And so AGA is for appropriate for gestational age, weak muscles, abdominal muscles, dislocated hip, undescended testes, B is large for gestational age with macroglossia, creased earlobes, and omphalocele. C, small, flattened nose, bell-shaped chest, and talipes. D, small with a prominent forehead, bell-shaped chest, and short limbs. Or E, small ears, nuchal fold, and truncal hypotonia. Okay, and the majority got the answer right, so it would be C. If we look back, oops, didn't have to look back, it was right there, of what I was getting at with the other choices, A is talking about Eagle-Barrett syndrome, where you do have weak abdominal muscles and undescended testes. I think it's a urethral obstruction usually. B would be Beckwith-Wiedemann syndrome. D could be some type of skeletal dysplasia, and then E could be trisomy 21. So the Oligohydramnios Tetrad, it's a deformation from prolonged fetal compression. So it's non-specific. It could be as a result of a variety of different things like renal disorders that cause low or no amniotic fluid, or it could be because of prolonged rupture of membranes. And so it's a deformation through constraint. So usually what you see is some kind of facial compression. So you see like creases under the eyes, aberrant hand and foot positioning with contractures, late IUGR, and pulmonary hypoplasia, which unfortunately is what usually causes death. And this is another picture showing the side profile with the flattened nose, enlarged kind of pushed down ears, and a small recessed chin. Okay, next question. Which of the following discerns bleeding into a cephalohematoma from a subgaleal bleed? The size of the mass increases over 24 hours. B, the resulting mass is fluctuant. C, the resulting mass has a distinct border. D, the mass can push the ear forward. Or E, the mass can lead to bruising around the eyes. Okay, so the cephalohematoma, the mass has a distinct border. It's good. For A, that's technically not incorrect, but the size of the mass would increase for a subgaleal bleed over 24 hours, and it would increase probably for a cephalohematoma too over 24 hours. So a subgaleal hemorrhage is strongly associated with vacuum extraction devices. It's a type of scalp trauma where if traction is being pulled on the scalp, the connective tissue layer moves, but then the periosteum layer doesn't move, and there's these emissary veins in between that can shear and tear, and there can be a large amount of blood loss. So this is a picture of a baby with a pretty severe subgaleal hemorrhage. It straddles the suture lines. It causes discoloration because of the bleeding into the scalp, and it can cause the eyelids to look black and blue. The ears can get pushed forward, and because that subgaleal space extends over such a large area, the baby can lose a lot of blood into there. This is a baby who was one of my colleagues' patients, and I thought it really shows like the bruising of the forehead and the eyes. Most subgaleal hemorrhages develop gradually, but you can see on this baby that there is kind of a fluctuant area there that's kind of almost like a fluid shift where it moves when the head gets repositioned. And if it's severe enough, the baby can experience hypovolemic shock. A caput can also look very boggy, and sometimes it's hard to tell the difference between that and that subgaleal bleed, but the caput is just edema, it's not blood loss, and so it shouldn't enlarge after delivery. It usually feels pitting, like you can put your finger on it and it leaves a dent. It's not fluctuant. And it typically gets much better very quickly after birth and then just leaves a circular area of bruising. Cephalohematoma, the blood's caught beneath the periosteum, so it's unable to cross the suture lines, and it stays limited in size. So this is just a little chart to summarize which ones cross the suture lines and which ones don't. So cephalohematoma doesn't cross. The subgaleal and the cephalohematoma can increase in size over 24 hours, where the caput should get much smaller. And both the cephalohematoma and the subgaleal are going to feel kind of fluctuant, but the subgaleal has more of a boggy feel. Okay. The delivery room finding in this image is strongly associated with which fetal condition? Hydrocephalus, in utero drug exposure, macrosomia, multiple gestation, or prematurity. So majority chose macrosomia, and that's the correct answer, because what it's showing is that the baby has a flexed tone everywhere but in one upper limb. So that looks like a brachial plexus injury, probably an herb palsy. So herb palsy involves C5, C6, and often C7 nerve roots. When the baby who's symptomatic has an internally rotated shoulder, elbow extended, and then a flexed wrist. Klumpke palsy is lower down on pulling or avulsion of the nerve roots, and so that leaves a hand that doesn't move, but the baby's able to move the elbow and the shoulder. Fortunately, most of the cases are not actually avulsed nerve roots, they're just kind of stretched, and so most of them will resolve. But oftentimes the differential diagnosis for if it's Erb's palsy or not is there a clavicular fracture, and they often go together, where 50% can have a fracture. So the risk factors are shoulder dystocia in a large baby, weight over 4 kilos, and the incidence of all birth injuries increase as the fetal size increases. And that is all I have. It's 13. So thank you.